Nikki.
Nick.
Thanks for doing this. Thanks for being here. Really excited to have you.
I am elated to be here and was really pumped when you asked me to be on it. So
Yeah.
I've been a fan since you launched it. And
Yeah, thank you.
Yeah.
We're trying to make it accessible, to highlight staff, to highlight friends and colleagues from around the country, to talk about what it's like to work in the field or being in recovery or whatever might come up. So it's really important for us to just try to keep it casual so people can access. So you are a Jedi Knight in my mind and a good friend of mine. We're kind of like conference buddies now these days, right? You
Completely.
sort of have your
I feel like we're
group.
more than conference buddies. Like we're,
That's true.
Yeah.
That's true. And we're not cliquey, just to be clear for anybody that might be watching.
Correct.
Friends and family only, potentially. We're very welcoming.
Very.
Not cliquey at all. But you, I just want to sing your praises a little bit because you've been in the field for a while and your name is Nikki Soda and you're the membership officer for the National Association of Addiction Treatment Providers. And what I really respect and love about you is that every conference I'm at, you are making sure people feel welcome, which if anybody feels like I'm not good at that, it's not because I don't like you. It's just because I'm a bit of an introvert.
Right.
And so I get a little overstimulated. And so then I just like sit in the corner
Completely
and
understand
charge
that.
my batteries. But just job well done with your work at NAATP and how much it's grown over the past few years. Just since I've been involved over the past 5 years, it's just been a pleasure to get to know you and just be a partner in supporting all providers. I really mean that.
Yeah. Thank you so much. And that's really kind of you to say. And conferences are a unique beast, right? And something that I get my energy from. I'm an extrovert, but it's so important to be inclusive. And so one of the things that I like to consider myself as a connector.
Yeah.
And so conferences give a prime opportunity to be able to connect people. And I always try to seek out some people who might feel, who are new. And
Right.
And so that's important for me.
Well, you and your team, shout out to Marvin and Katie, Zane, I'm going to forget names now, Beth, Annie.
Right. Luke is our new communications
and Luke
manager.
is new. Y'all do that very well. I've always been so impressed because I've been to conferences where it feels very exclusive and the NAATP's things always feel very inclusive. So
Good.
Just job well done.
Thank you very much. And that's good. That's good to hear. And as our field becomes, we're trying to make it more inclusive. And so it's important that we if we're talking about it all the time, then we need to show it, right? I'm a firm believer that actions speak louder than words.
Yeah.
And so I'm glad to hear that it's
We
working.
got to stop talking about it. We got to be about it,
Right.
Yeah.
Yeah, I like that.
So I know a little bit of the story, so I'm kind of cheating a little bit. But
Sure.
just, if you may, how did you get into this field?
Yeah.
You know?
Well, so I will preface it with I'm a woman in long-term recovery. So I got sober in April 2004. And
Congratulations.
thank you. My background, though, I majored in communications, and event planning was really my forte. And so I did corporate and nonprofit event planning, and then I did high-end wedding planning for a long time and thought that was my dream job. And it was at the time. My husband is a therapist, and I was getting a little envious, to be honest, that he was around recovery all the time.
Right.
And we went to a holiday party, and I was talking to, his name is Ben Court, and he was at Cedar at the time, and we were just kind of shooting the stuff. And he said, well, there's jobs that you can do events. And I was like, what?
Right.
This was back in, I think, 2011. And I had no idea. I truly had no idea. I was an active alumni at the treatment center that I went to, but didn't know that the job. And so from there, he said there is actually a position that does marketing and alumni at Harmony, which is up in Estes Park. And he said, let me give you Marvin Ventrell's phone number. He's the director of business development. And so I reached out to Marvin. I'm like, listen, I have my life experience. I'm like, here is all of my work experience in organizing and event planning, and give me a shot. And he gave me a shot at Harmony. And I could not have asked for a better place to have started my professional career in the behavioral health field.
Yeah.
And so that's how I got started. And I've I never do things by dipping my toe in. So I dove in head first,
Right.
and it's really been a wonderful ride that I feel like is just kind of getting started, and that there's a lot more growing to do.
Yeah. So tell me about your experience working. Harmony's a great program in Colorado.
Correct.
Estes Park.
12-step based, yes.
Beautiful, by the way. I was there maybe 2 years ago, and I think it was the elk that were like
Bugling.
Yeah, and screaming, and it's just a beautiful gym.
It's a little alarming at first, right?
It was. I
Yeah.
was like,
what is that?
Is this supposed to, but it was, I was like, okay, we're, in the Rockies, like this is the experience that you want to have. And It's beautiful up there. But for those that might not have experience, boots on the ground, supporting a legacy 12-step based addiction treatment provider, what did you learn professionally? What was it like day to day? What insights do you take from that experience that maybe translate to your work today?
Yeah, that's a great question. First, I'll have to say that there was so many more components to it than I realized from being a patient in residential treatment. And so that was very eye-opening to really learn and understand all the different departments that there were, and how they work together, and how important it is for them to work together. And so one of the things I would say right off the bat was, seeing some silos. And so not saying this in a negative light, it was just one of the things that I saw and that we had group meetings about. And, they're not the only treatment center where admissions sometimes works very separately than business development. That sometimes works separate than clinical. And so for me, being able to work there and see how they overcame those challenges and how they worked through them to create solutions was very eye-opening. But one of the things, too, that I want to say is the power of the alumni. And so I'm a huge advocate of alumni, but having them come back on campus, and I would part of my job would be to meet with the patients that were getting ready to move on. And because at Harmony, it was just residential, so there was no step down. And so I would meet with all of them and go through continuing care apps, how to find meetings, how to reach out to a sponsor, things like that. And for me, it was really, really cool to see the change that happened, but then to see and stay connected with alumni as they went out. And so for me, that was one of the really powerful things of seeing how the benefits of a treatment center and how it works. So that's another component of it. But then reaching out in the community, and Colorado at that time had about 6 residential facilities in the whole state, very, very tight-knit community. So I was able to really be embraced by the other treatment providers and had a good group of mentors, which I'm a huge proponent of mentorship. And so knowing that I was working at an ethical facility and being able to formulate collaborative relationships with other really good treatment centers, it taught me a lot and gave me a really solid foundation.
Yeah, you can really get a lot of insight, and this is might sound a bit combative, and I hope it's not, but how integrated is an organization with other peer organizations, providers in their community is super important, right?
Right.
If they're disengaged for whatever reason, in the absence of information, a narrative can get created for good, better, and different. Oh. And so provider like Harmony continues to, certainly at the national level and regional level, be a solid, trusted partner, because there's enough folks in that state, just like there are enough folks in Tennessee for Cumberland Heights to fill all of our programs.
Right.
There is no competition, and there is value in that collaboration and joining together to make sure that we're building an effective atmosphere of recovery to support people. And it goes beyond the treatment centers too. It's the schools, it's the other partners, that maybe mental health partners or academic partners that are coloring and helping supporting your alumni base. That's super critical.
100%. And there's 2 things that came to mind though. There was a CEO group of those 6 facilities in Colorado that would regularly get together, Bobby Ferguson being one of them, and who's the CEO of Jaywalker Lodge. And they were so willing to help each other out and work together that for me, that's how I thought it was everywhere. That was my first job opportunity in this field. And so that really set a stage for this can be a collaborative. So when I started going to different places and I was seeing, it's not like this everywhere. This is special. And so that's something, though, that I'm really glad that I was able to experience and see, because I try to share that information and get other states to do it. And Tennessee is you guys are good about having collaborative.
Yeah, you have to be intentional,
right?
You know, well, you have to be intentional. You can't just have good intentions. You have to take action.
Correct.
I guess maybe that's a better way to say it. And what does that really look like pragmatically? Well, you have to spend some of your organizational dollars.
Right.
You have to spend some of your FTE time at making sure that your outreach teams or your alumni support teams or your peer recovery support specialists are out in the community and really building relationships. And I am not talking about referrals.
Right.
It is not that, right? It's not front end. This is back end of these businesses to make sure that patients are really supported appropriately in their community. And when that happens, it's a real beautiful thing. And that's where you get these events or a picnic or a concert, like we're going to have our annual concert tonight, and it's going to be standing room only with our friends,
right?
You know, with people who care about recovery and want to support people getting well in Tennessee,
right?
You know,
and so the main word is care, and I think that that's something too that is an essential component from a CEO is to care.
Yeah. Have you ever thought of, so as you're talking about your story, one of the things, there's a common thread with you that I think is interesting that I just thought of is that
well, lay it on me.
Your experience at Harmony and understanding how important those relationships were in mentorship, absolutely no doubt in my eyes, as I've gotten to know you over the years, colors what you do day to day and the actions that I see you taking with NAATP. Do you see that connection? Do you think that was a part of what kind of motivates you to make sure that people feel welcome?
Oh, definitely.
Definitely. Because a new person that's,
Oh, for sure.
Yeah.
Because I've been on both sides of it.
Right.
I've been on the newcomer really needing to have guidance and knowing how important it is to have good guidance.
Yeah.
And now I feel like I'm growing and I have 3 mentees right now. They are rock star women who sometimes I'm like, I don't know why you're calling me.
Yeah.
And that they call me regularly for professional advice.
Yeah.
And I hope that I'm a help to them. And so I see it twofold, and definitely.
Something else that's really interesting about our field, which some people are aware of, maybe others aren't, is there's so many folks that are operating these programs, running these programs, working in these programs that are in recovery themselves.
Right.
So I think about our experiences like being in Vermont with High Watch and being at Bill Wilson's childhood home, or making sure that we hit the meeting at the conference, the 12-step meeting,
right,
or going out after an event and doing a recovery activity. It is so unique to be able to share that professional development and also recovery development
right
with folks that work all over the country. It's maybe the most special part of our field.
Without a doubt. Yeah. I feel that way. And that's, I feel such passion about that. And for me, it's sometimes work doesn't feel like work. Like
right.
being up here and getting to do the things that I'm doing today doesn't feel like work. And part of that is because we get to talk about how I get to learn how Cumberland is helping people. I get to learn you as a person in recovery, how you're helping people. And then we get to weave that together, and then we get to get paid for it.
Right.
And it's really special, and it's rare. And, I have a lot of friends that are not in recovery, and their jobs are very, very different. And so it's not to say it's better or worse, right? It's just, it's different. But I try not to take a day for granted that what I get to do is unique in the fact that I get to be around a lot of people who are in recovery and who, it's the promises coming true, as cheesy as that sounds. But I'm really grateful for the job that I have, for the fact that I get to do those things.
Yeah, you get the unique opportunity. We were talking earlier when we were at lunch with several people, and a part of your job is to go across the country and visit providers and you really get to know the people that are running these facilities and kind of celebrate, their success and their ability to serve their communities, which is super unique, right? Because sometimes the staff that are working at these places, oftentimes most of them aren't having that experience.
Right.
Of going to Colorado and sitting at the round table, or in Maryland, and you know what I mean?
No, 100% I do, which is a part of what makes me good at my job, is the fact that I'm able to go and absorb and take notes and see the good things that providers are doing and
make connections. Because I can't tell you like how many times you've texted me and been like, hey, I just met so-and-so, they're a new provider or they have a new program. I thought of you for this reason. All the time, which is so beneficial.
And I love doing that. My friend Mallory, who works at Brookdale, I know she said it, that she's a people connector. Yeah. And I'm like, I'm borrowing that.
Yeah.
And that's something that I like to do. And so part of me traveling across the country and getting to visit is that I get to learn and see what different people are doing. And a lot of good things that can be translated and connected. And I also see some not so good stuff, right? And so I'm able to then take that information and see if there's something from the association standpoint that can be done. And we're not a regulatory body by any means, but sometimes there's things that, because I see so much, that I can take back and be like, maybe take a look at this.
That's something that I really value in my experience with our trade organization, with NAATP, so I love what you're saying, because in some ways you have your finger on the pulse of the field in a way that's unique, and those observations can maybe inform or complement the strategic goals of the entire grouping of 1,000 providers, right?
Correct.
Over 1,000 providers in the U.S. and maybe beyond.
Yeah.
I'm curious, how does NAATP codify that? How do you guys support providers around the country? What do y'all do, if you will?
No, that's an excellent question. And so we have a number of different really good services and benefits that we offer to our members. We'll go back to that connection piece. I feel is one of the greatest benefits, is being able to have this network available at your disposal to pick up the phone or send an email, ask a question to. If you need somebody in a certain state, we can help find that certain person. So that connection is really important. And it's something too, you've been vetted. And so if you're talking to another NAATP member, that you're talking to a qualified provider. So I think that's a huge benefit. We have a number of different resources that we are constantly pouring out. So Dr. Annie Peters is our Director of Research and Education, and she does a really good job of being able to pull in new information. And we put out white papers. We're doing monthly webinars. We do a number of blogs too. So those resources are I believe, really helpful. And we do them for every department. So you have HR resources, operational resources, and clinical.
Yeah.
And then we have advocacy. And so we do have a director of public policy who lives in D.C., Mark Dunn. He does a wonderful job. He's been with us for a long time, and he's boots on the ground in D.C., really keeping a pulse on federal issues. And part of my role now is I've taken on state advocacy and working on creating state chapters to ultimately create Recovery Hill Days in every state is my goal.
Let's do it.
And so advocacy is a big part, because a lot of times, like, let's look at the opioid settlement money. There is a lot of members who don't understand how this process works, and it's different within each state.
That's right.
And so we want to be able to be a resource to help navigate through issues that come up like that. So those are a couple. And then I would be remiss if I didn't mention FORCE, which is our Foundation of Research, Science, and Education. And Dr. Peters has done a phenomenal job, and so have you. And so I want to give, now it's my turn to call you a Jedi for being able to create this wonderful initiative. It's more than an initiative, but it's so desperately needed in our field. And to be able to bring together outcomes to show, not only for me, showing the data to policymakers is imperative, but it's also to insurance providers, and then it's also to community members to say treatment works, here is what's working, and here is our proof to show it. Because without those numbers, without legitimate research and the scientific data to show it, it doesn't mean anything.
Right.
And so that would be another huge benefit.
And your annual conference. That's really how I got involved with NAATP in my role at Cumberland Heights. Of course, Jay, our CEO, has been involved for a number of years, and I would be remiss if I didn't mention y'all's work as a trade organization with the Ethics Guidebook a number of years ago, and Peter Thomas.
Right, that's another big part.
Yeah, which was a huge revision to the standards of ethical responsibility in our field, which I think has been a really great thing.
Yeah, can we talk about that for 1 second?
Let's talk about it.
I skipped over that. And Peter Thomas was our director of quality assurance, and I call him Detective Thomas.
Yes,
because he is so good at ensuring that the I's are dotted and the T's are crossed. And so for our ethics, we created a code of ethics that went out in 2018 or 2017, excuse me. And so at this time, marketing practices were going really by the sidelines in a number of facilities, or a handful of facilities, I should say, but they were becoming extremely detrimental to community members who were looking for a specific thing in a treatment center, and the website could have a picture of a facility on the beach, be very deceptive and very deceiving. And so we cracked down on that, and we created this code of ethics that we asked every member adhere to. And we had some members who said no, who flat out said, no, I won't do that. We gave a number of chances for members to make the correct revisions that needed to be.
Right.
And they were really reasonable revisions.
Right.
And so we lost a number of members in 2017-18. But then what happened is we gained a whole bunch.
Yep.
Because we go by the premise of quality over quantity. And so losing some folks, losing some providers who were not willing to adhere to a code of ethics, we were able to get more who said, no, I wasn't a member before because you guys were letting these players we were in now.
Yeah. It's our responsibility.
Right.
And I feel real strongly about this, and this kind of colors in between the lines with Force and what we've done at Cumberland is when I started here, really solely focused on research, one of the first things that we talked about as a leadership team is we want to be able to communicate with patients, external stakeholders, partners, and payers, but mostly and most importantly, I would say patients and their families, how we measure success.
Right.
And I have a thing that I say all the time, which is newsflash, no one owns algebra.
Right.
So sometimes organizations are very, smoke and mirrors, if you will, about how they measure success, the tools they use, how they analyze it. What secret are we really keeping? And so since I've been here, we've actually published, it's on our website 365 days a year on the front page.
Right.
Right? An annual outcomes report. And it's not a marketing tool. It is, hey, these are the things that we think are traditionally associated with addiction and treatment failure risk. These are the tools that we measure them with. And these are the data in the aggregate, right, for you to view in terms of what our, quote, success is. With the limitations, because they are not perfect data sets and we have work to do. But we have found it was interesting, like to be transparent,
Yeah.
which I love to do, and overshare at times.
Well, which you clearly are transparent by putting it on the front page of your website. And it's yeah. So that's
I think as an organization, we had never done that before. Mm-hmm. And I think that there was a little, not enough for us not to do it, but there were certainly conversations about, wait, should we do this? Like what are the risks associated with that? All this kind of stuff. Ultimately, we decided it was just in the best interest of transparency and making sure that we're informing patients and their families, consumers, about of what they should expect in treatment and how, again, we view change. And it's been really valuable. Like we get so many comments and interestingly enough, suggestions for revision. So many of our ideas year over year where somebody says, this is all great, but I'm actually really curious about family participation, right? Or length of stay or whatever it might be that helps us kind of get better.
Sure.
And it's been a pleasure to be involved and get to know the stakeholders at NAATP and really work with Annie at building Force. And I'll tell a quick story because we met, shout out to John Driscoll and Bobby Ferguson and Marvin and Katie, because we met in the Denver International Airport in 2019, because this is right before the pandemic.
Right.
No, it was 2020.
Oh, okay.
Because the news was kind of going around about, the West Coast. that we all remember acutely.
Right.
And so we had a meeting where there were lots of ideas. We had a consultant that was guiding us about what we should do. And at the time, John was the chair.
Yeah.
And there was a lot of talk about that NAATP is going to do something and what should we do. And so I'm really proud that what we proposed was, hey, we need to collect data together, de-identify. We need to be able to visualize it and share it amongst our provider groups, right? So that the public can be informed, because I firmly believe that our future ability to advocate for our programs will be almost entirely grounded in data. It is the language that other science disciplines speak in. And if we don't invest, it's sort of like, if not us, who mindset. And so I'm proud. I wasn't in the conversations about the financial piece of what this would cost to take this root to fruit, but the board decided we're going to pay for this. You know, we're going to put our own money kind of where our mouth is, if you will. And they raised a lot of money. Again, Bobby Ferguson was very involved, and they had a group that was very involved in raising money. But it's been a pleasure, and now it's kind of like, oh shoot, we have a lot of data.
Right.
We have like, close to maybe 250,000 now of unique treatment episodes in terms of unique patient.
Which is so exciting.
Yeah, 80 facilities. I mean, it really reached a fever pitch, which is what it by design.
Right.
And so I'm excited to see where that goes in the future, to just improve our practices, inform our patients, and communicate externally.
Right. All three of those things, which of course are imperative, but I look at it too from an advocacy perspective.
100%.
And as another passion of mine, it is just going to be so incredibly helpful. It already is, to be able to take that information and say, here it is. This is undisputable. And this is why we need to either keep things the way that they are, or this is why we need to make changes.
Yeah.
And we need your support on this.
So I have one more like soapbox statement about that. And I think that one of the things that behavioral health struggles with is the medicalization of behavioral health. Mm-hmm. But here's really what I mean. Like, let's get practical, because you hear about that. There's like a webinar about that or whatever. And you're like, well, what does that mean?
Right.
This is what that really means. If I break my arm, right, we have measurement tools in medicine to take pictures. Oh, turns out I did break both bones in my forearm, right?
Right.
X-ray. And then we have a treatment regimen, in terms of, well, maybe I should isolate it. I'm probably going to cast it. I might take some medication to reduce inflammation. And then my physician team is probably going to monitor progress of healing of those bones over time. And when it's healed, then hopefully, ideally, it'll be back to use as it was before.
Right.
I think that there is an expectation with the dominance of that medical binary mindset, which is helpful for bones, helpful for kidney disease, etc. But behavioral health change is always a process, not an event.
Correct.
Right? So the epistemology, not to get super nerdy, but the theoretical underpinnings of how people change and related to behavior is not organized under the same philosophy.
No, it's not.
Right.
And it cannot be, or this is my personal belief, this is not of the association.
Gotcha.
Is that it cannot be changed purely by medicine. It
Correct.
has to be.
I believe that
it
too.
has to be more than that.
Yeah.
It
can be complemented by.
Absolutely, without a doubt. And sometimes
it should be.
Yes, and it should be. But you cannot expect someone to fully change by just giving them medication.
Right. Another personal example is I'm long familiar with the nature of my problems. Shout out to myself, right? Long before I'm willing to do anything about them.
Right. Right.
And in my professional and personal experience, change is often not driven by insight and more often driven by action. And this isn't just for anybody that's like feeling really upset in their car and are going to text me. I'm not talking about like pulling yourself up by the bootstraps. That's not what I mean.
Yeah.
I mean, surround yourself by a community that can be your eyes and your ears. Surround yourself by a professional treatment team that can help expose whether it's trauma or maladaptive coping mechanisms that you develop in your life. Surround yourself by an impassioned purpose that you might be able to discover, and that will translate to the process of behavior change. But expecting people to stop being addicted after a 30-day treatment stay is just not, and I think that our lawmakers and those outside of the day-to-day field of behavioral health, it's a miscommunication, right? It's not nefarious. It's simply that we just aren't speaking in a language that they can hear in, which is why I believe force is very valuable.
Yeah, no, very well stated, and I completely agree with all of that. And I think too that, the discussions about the medicine and behavioral health lately, I hear a lot more that people want to change behavioral health, the term behavioral health. And so I ask them, I say, so when I say people, it's comments on social media. Let me take a step back. But then I ask, okay, if it's not behavioral health, then what should we call it? And nobody has a good answer. So, some people just like to, but I do think it's behavioral health because it's health and it is behavior. And we have to change both of those things in order to heal.
Yeah.
And so
I want to push you more on this from your experience and your vantage point in the field. How are we changing? What's evolving? How do you see providers stepping up to the plate, if you will, to the current problems associated with addiction and co-occurring disorders?
Yeah. So there's two main things that I'm going to say about changes in the field. One of them is acquisitions and mergers. And so that's not
Let's
coming.
talk about it.
It's not coming from the medical perspective.
Yeah.
It's coming from, we are seeing less and less of the facilities like Cumberland, let's say. And we are seeing more and more of not even necessarily corporate, but we're seeing of bigger conglomerations that are buying up facilities, right? And so that's a huge shift and a huge change, and that has an impact. And I cannot tell you how many colleagues I've had who work for facilities that have been acquired by someone that are promised nothing's going to change. Everything's going to stay the same. And that is, can I cuss?
Sure can.
That is bullshit. That is bullshit. Things are going to change. And particularly when you have larger entities that are run by, and I'm not saying that every CEO needs to be in recovery. Absolutely not.
I get it.
Absolutely not. But when you have an entity, I might get in trouble for saying this, when you have an entity that's not run by people who understand recovery, people who are money and bottom line driven, it's going to be a different outcome.
That's right.
It's going to be a different outcome.
We'll get in trouble together.
Okay.
I'll jump in this boat with you.
Okay, good.
And I'll share my experience.
Please.
And if you're disinterested in hearing this part of the podcast, jump forward. Let me say this. There's a lot of really great providers out in this country.
Without a doubt. I get to see them.
And people change their lives by going to these places. And I am in no way, shape, or form endorsing that we have discovered something special or that we are legends in our own mind here at Cumberland Heights Foundation. I believe that, right? We are somewhere above average is what I would say.
You are a special place, though. I do want to interject that.
I appreciate that. But an equity fund purchasing a behavioral health program like an addiction treatment provider is focused, their first customer, as quiet as it's kept, is the investors. Let's not be confused about that.
Correct.
Right? And
Yeah.
I hope I have many friends that work for Equity Back, and there's a great program. So it's not
As
all
do
of them.
I,
That's
right.
not what I'm saying. That's
Right.
not what I'm saying.
And
Right?
great
So
care
nobody
is coming
come
out
at
a lot
me
of
in the
them.
Good thing is I'm not on social media.
Right.
Christina runs our social media, so she'll let me know when the comments flood in.
My
or
name
the direct
is Maria
messages or whatever.
Smith on social media.
Yeah. So I don't see it, but the primary customer is the return, right? It's not the patient. That's just a fact. That's not an opinion.
Right.
Right? And so when you string together, like you're talking about, 5, 10, 15 of these organizations who were once legacy providers as an example or whoever, and you're monitoring a shared EBITDA, that's what it tends to be about. And I hate to say this, but I think that there aren't incredible margins in behavioral health.
Right.
We don't get into this work because we're going to get rich. Right?
I mean, we don't, but I definitely, yes.
And so generally speaking, what I've seen from some providers is a reduction in FTEs to the bare minimum. And I think that impacts patient care.
Without a doubt it does.
And so if I were to, this is what I would tell somebody that's trying to make an informed treatment decision, is understand what the ownership of the organization is like, and the other programs that they're affiliated with, so that you can make an informed decision about the nature of care, because there are different standards. Although we're all licensed by the state in which we're providing services, and generally we're accredited, right? Either through CARF or Joint Commission. But those are bottom standards.
And outcomes. Let's say that too.
Yes, and outcomes.
So how they're doing them, because I think that how they're tracking them, I'm putting air quotes, and because there are some places out there that say that they have a 90% success rate.
Yep.
And it
very
is not
dangerous.
Yeah, it's
and
not
negligent.
It is. And so that should be another question that you are looking at when along the lines of licensing accreditation is also, are your outcomes valid?
Right. So yeah, that is a big change, over the last, because I think in some of the SAMHSA, it might be the NSATs or the TEDs, which I can't remember which one it is, where it monitors basically the financial status of the organization as a function of is it a corporation, is it a nonprofit, et cetera. Is it for-profit, nonprofit, and how they break that out. We are seeing, and Marvin and y'all's team does a great job of visualizing.
He does, yes.
With the shout out to Marvin, the bubble chart.
Yeah, that's a popular one.
Yeah, because it's a great visualization tool. And,
it is,
and it's really interesting when he shows when his team started,
right,
and all the little dots, and now when you look at it, and they're big bubbles, and it is a change.
It is a change, and I'm curious too what it's going to look like in 3 more years, because I think they'll be even smaller. And part of my hope, though, is that the facilities like Cumberland Heights, like Harmony, High Watchalina, there's multiple that are still those small bubbles that provide really, really good quality care that continue to thrive and
again,
stay
we
that
don't
way.
have everything figured out. That's not what I'm saying at all.
Right.
And we certainly hope. We've been providing service in Tennessee since July 25th of 1966, which is 57 years, which that doesn't make us perfect. We've made so many mistakes. We've made all the mistakes, right? But we hope to continue to serve this community.
For sure.
And we're proud of the lives that have been touched. And we're excited to continue to be a partner at the national level, and especially at the regional level, for all the other providers that are just as successful, quote unquote, as we are in our area. Like shout out Ian Henyon, who is here this morning with Birmingham Recovery. Learning a little bit. I was joking with him because he took the nerdy tour,
right?
The untraditional business development. He wanted to know more about how our data infrastructure is set up, and so we had a fun time nerding out together. But look, we're all here to support, and I have learned so much from other providers in our area, and will certainly continue to do so.
For sure.
So mergers, acquisitions is one. Mm-hmm. What was the second one you were going to mention?
The second one that I was going to mention is more gearing towards the peer recovery medical models. I hesitate because I feel I hesitate.
Yeah.
And so we see a lot more of that. And I think that it's imperative to combine and blend those, but we definitely see a much larger shift.
Yeah.
And I think that there's a multitude of reasons why we're seeing that. And so I am not trying to toot my own horn by saying this, but I just graduated in May with my master's, and
toot that horn. Yes, you did.
It was taught by the creme de la creme in DC of public policy. And there was not very much on residential treatment, like very, very little. And majority of it was on medicated assisted treatment, harm reduction. And so I would be remiss to say that there's not a shift in that we're seeing from a macro level.
Can I tell on myself a little bit?
For sure.
Years ago, I was a graduate student. Loved being a graduate student. because I can show my butt.
Yeah.
I was at an ARHE conference.
Okay.
Association
You may want to
of-
say, yeah.
Yeah, Association of Recovery and Higher Education, which are focused on CRCs, collegiate recovery communities, and collegiate recovery programs, which are great programs. And it was in DC, and at the time, the deputy director, I can't remember his name,
Who was president?
Obama.
Okay, so Michael Botticelli.
That was it.
Yeah, he was
doing a presentation, and he was with the Office of National Drug Control Policy.
Yeah.
So Office of the Drug Czar in the United States.
Oh, yeah.
And he did a presentation on MAT. And so because I was a graduate student and
God.
I have personal experience in this like plenary, felt the need to ask so many questions about why the federal government was so in support of MAT for some of the reasons that I alluded to in terms of I felt like if you're just looking at MAT, through a keyhole, it's an incomplete picture of all the resources together that can really create change. And I learned an important lesson because he really checked me. First of all, he was so accessible.
So excited. I've had coffee with him.
And so humble. And in spite of my ego being completely out of control, he took time to talk to a graduate student who was and is a nobody, right?
I disagree with that, but go ahead.
And he just said to me, Nick, I hear you. And he did some self-disclosure, which I won't do on this podcast.
Right.
And he said, you have to understand that this is a different quiver, right, in our whatever holds the arrows, or a different arrow in our quiver, rather.
Okay.
And that harm reduction is different than treatment. And what we're recommending is that the data, which I agree with, that MAT does two things really well. It reduces craving.
Correct.
And thus reduces overdose incidents.
Mm-hmm.
And that gives us the opportunity to save more lives and ultimately try to provide access to a life-changing trajectory of recovery. And in that moment, I thought, what a great lesson to remember about how our field is changing and how we need to make sure that we're best informed about how these modalities are adjusting.
For sure.
And make sure that our personal experience isn't discoloring the reality of how many people suffer, because MAT has saved hundreds of thousands of lives.
Oh, without a doubt. Without a doubt.
And for those people that are on it, I am so grateful that we have life-saving medications.
Oh, me too. And I have friends.
And I used some of those medications in my personal recovery when I was detoxing.
Yeah.
Right. At Cumberland Heights.
Yeah.
Right. So who am I? Who are we even sometimes as providers to tell people what avenue that they should start their recovery? I think it's our job to make sure that we provide as many of those roads, and then kind of equifinality. All roads do lead to a recovery identity.
Sure. However you
That's right.
describe it. Where it becomes a little bit tricky though, and I'm curious your perspective on this, is like if let's say you're in a treatment setting, you're providing all these different roads and avenues, but you have some people who are using and you have some that are not. But so, for example, in Florida right now, I need to be a little more updated on this bill, but medicinal marijuana is being okayed in recovery residences. And it's very easy to get a medicinal marijuana license. And so they are saying that it's not okay for recovery residents to say, no, you can't have. And so for me, that's where it gets a little bit tricky of that blurred line there of your definition of recovery can be different of what my definition is, but we also want to, keep people safe. And so for me, that part I'm trying to figure out.
Yeah, and also we're seeing a lot of work, which I think will be a good thing ultimately with hallucinogens.
For sure.
With psilocybin and ecstasy, MDMA.
Yeah.
And what's interesting is that hallucinogens show to be the most effective drug that we have for nicotine cessation.
Oh, I have not seen that.
Which is really fascinating. And so the DEA has expanded, academic universities access to doing these investigations. And it's a really fascinating space and place. I think it's important to remember that we're talking about addiction treatment
Sure.
in the scope and scale of all of behavioral health,
Right.
too, right?
Right.
And so it remains to be seen. I think that we want to remain open-minded
I agree.
to understand how the science community might suggest these things could or couldn't be helpful for future patients. But I'm kind of with you. Like, it does give me pause with an addiction population.
For sure.
Right? Because what I know is somebody living in recovery is living in an abnormal state.
Right.
And so based on my experience, for those that are having access to a medicinal marijuana license, as an example, that can be a slippery slope by way of continuing to access that drug and or other drugs that are mood changing and mind altering.
Right.
Right. Which is ultimately a part of the problem.
Correct.
So,
Yeah.
but I think there's enough space and there's enough hurting people
Right.
for us to, they don't have to be mutually exclusive, and they don't have to, what's the word? Like, threaten.
Correct. They don't have to compete either. So
Yeah.
we can have them. It's just figuring out how to safely do all of them, I think.
Do you think from an advocacy perspective, I mean, when I think about this, it makes me, force becomes even more important.
Oh, yeah.
To be able to tell the story of residential, even PHP, extended care programming as a function of peer recovery support and IOP.
Right.
Right? Because access to treatment is a huge issue in this country.
Ginormous, yes.
You know, and the cost of our programs, I mean, for perspective, like, you know, Cumberland Heights is a nonprofit, but, you know, to run a residential center, you know, we have to maintain certain ratios in terms
Sure.
of staff to patient. And we also have to have medical professionals and all the other folks operationally that it takes to run an organization that has, you know, we have 350 employees, 20 different sites. And so we're an in-network provider, proudly.
Good.
But it still is very expensive.
Yeah.
You know, and unfortunately, most Americans cannot afford to send their loved one to what would be known as a private provider. And so I'm curious about your thoughts about the future of advocacy and maybe like the expediency to which we should be paying attention to this to try to advocate for our programs more effectively.
Sure. So access to treatment is something that I myself am a huge advocate for, figuring out how to make good treatment more accessible. And it's also part of NAATP's public policy statement, increasing access to treatment. And so it's one of those tricky things too, where it's like we have thousands of beds out there across the country, right?
Right.
But then we have waiting lists at state funded facilities. I know I live in Palm Beach County. We have one for indigent individuals without health insurance, and it always has a wait list. And so it's being able to figure out how we can help more people. And where it gets tricky, though, is helping more people, but then still being able to pay your expenses. Because so I don't have the answer to that. I wish that I did. But it's something that by, creating awareness sounds like kind of a bullshit thing to say, but it's really not, because it's being able to provide resources to the community at large and letting them know about the different options that are out there. Because I can't tell you how many times people will call and not have any idea where to start, which I don't blame them. Why would they?
Right.
But being able to really figure out where either they or a loved one can go. And so I think that's where we need more is that education component to, I think that would be very helpful, but I think there's something else that we're missing and I just haven't been able to think of it.
Yeah. And there is so much work. It's almost like a high tide raises all boats.
Right.
And it's like more of everything.
Right.
More awareness, more policy-driven discussions, more outcomes, more quality.
Parity is one that would be a huge help. And that's if insurance companies would reimburse fair. So what's fair, Nikki? If insurance companies would reimburse what seems to be enough to not only cover treatment, but to not constantly be disputing everything in order to save money. Mm-hmm. And so with parity, which was passed when Obama was in was in the during the Obama administration, we're still having a heck of a time getting insurances to pay what they should. And so I do think that would be a really big component if for mental health and for substance use disorder, if there was good coverage from insurance companies that weren't continuously being fought. So I do think that would help a lot with access to treatment. And so there was some movement last month within HHS, the Health and Human Services. And so parity we're hoping, got kind of an injection, so to speak, that the insurance companies their feet are going to be held to the fire, that, you have to cover these things. They are illnesses. And so
I'm hopeful that with the consolidation of insurance companies in this country, that because we have a lot of really great payer relationships who are willing to develop mutual scorecards, or create cross-sectional analyses about financial value, and post-discharge activity as a function of medical claims, so that we can better understand how much treatment is needed to save lives and save money for both the consumer and the insurance company over time. The problem, and shout out to Greg Williams, is most Americans switch their insurance coverage on average every 2 years.
Is that right?
So that's
interesting.
It's a kind of musical chairs, right? And so why would an insurance company want to invest in the long-term value, right, to save money? Because I believe the long-term value of investing on the front end for mental health resources comes out beyond 2 years. Washes out beyond 2 years, 3, 4, 5. But with the consolidation of insurance companies, I'm hopeful that those costs are going to be shared in these big companies vertically, right, from the providers and the payers, which are becoming one and the same. Right.
And to be transparent, so Greg is brilliant. And, he talked to us, speaking of Vermont, when we were in Vermont, to a group of CEOs and leaders in the field about being able to now see what reimbursement rates some insurance companies are giving. But it is what is an analogy I can use? It is really, really challenging to be able to decipher and get that information. One thing that I think would be really helpful, Nick, would be and this would take multiple people updating it all the time, but if there was an insurance directory of treatment centers, who is in network with who. And because when I get someone who calls and will say, Nikki, I have Blue Cross Blue Shield, who can I go to in Florida? And I'm like, you should be able to call someone at Blue Cross Blue Shield, but it's not that easy. It's not that easy.
I believe that's coming.
Oh, good.
And I can't remember the legislation. That's not necessarily my day-to-day wheelhouse, but with the access, so providers are now being held to the fire to provide machine-readable files, right, as a function of their services and costs.
Okay.
The problem with machine-readable files and having them available is almost nobody can read them.
Right.
I mean, you need a serving database to sort of maneuver through that minutia. So that might be helpful for a provider like us to say, well, where do we stack up with other providers in our area?
Sure.
As a function of our per diems or other things that we're contracted for, physician visits, et cetera. But the customers, i.e. the families and the individuals, having access to what you would think of as a portal system, kind of like how you buy a car, right? You never show up buying a car not knowing how much it's going to cost 9 months down the road, right? In fact, these days with medical, you can have a pretty fair amount of visibility on what it's going to cost to have a knee replacement.
Correct,
right?
Yeah.
It's pretty, this is what it's going to cost.
Right.
Right, but in behavioral health, it can be very variable. So I think that payers are starting to, we'll just say invest.
Yeah.
I'm not going to say forced to, but invest by way of some federal legislation and I believe that might be happening this year or next, to create a index or a component that is available to the public to go and search who are the network providers and what's it going to cost against my plan and my deductible and or out-of-pocket cost, which would be super helpful to make informed decisions. And
it's a shame that it's taken till 2023 for it to happen. Yeah. So I'm really glad really glad to hear that.
I want to shift a little bit and ask you about a different topic, which seems out of left field, but I think it really matters.
Okay.
As I think about how the acuity of our patients are changing.
Yeah.
The people that are touched by addiction is changing. Social media and our culture. Do you have any thoughts about that and about how it might be impacting our practices?
I do, and I see positive and negatives. I can see positive and negatives. I myself am on social media. My husband would probably say too much. But
we love you, Jim.
I think that with LinkedIn, I tend to trust a little bit more. That being said, there's still people who put some ridiculous bullshit out there. So I think it's very challenging, Nick, to decipher what's true and what's not. And social media makes it even harder to know, particularly if you have somebody who has a lot of followers and is putting information out that's not true. It can be very deceiving. And so, but I do think that there's some really good benefits to it. And so a couple of those that I know, SAMHSA puts out some phenomenal prevention tools. And so on Instagram, Facebook, LinkedIn, and so those are really helpful. Those can be really helpful not only to parents and to community. So I have a daughter who's 11, who's in middle school. And so I use a lot of those resources to be able to share with the school. So that's a benefit that I see. Another downside, we'll go back and forth. Another downside is my daughter is 11 and she is on Snapchat, she is on TikTok. And so we have talked about the dangers of what can come across there because they're not regulated. And that can be so detrimental to not only our youth, but to anyone who is watching it a lot and who is seeing something that's not true.
Yeah.
So, there's pros and cons with everything, but I definitely see with social media probably a little bit more downside than I do good side.
It's tricky. It's something that we're talking about more clinically here.
Sure.
Because we are starting to see it as a huge risk. Someone who puts their phone away, let's just talk about the residential level of care, who might or might not have access to social media and the barrage of posts you might see about some, who's getting engaged or who your ex-girlfriend is posting with or what your friends are doing. And it can become a microcosm of comparison that is so hard. Even for me, I say that like I've graduated to some higher plane of living. I have not, right? It's part of the reason why I'm sort of not off social media because I'm like, what purposes is really serving? I think there's an opportunity to stay connected with people.
Correct.
By way of communicating with folks that maybe you built a relationship with in treatment or other alumni in your area. We see that all the time with organizations sharing information about events. But gosh, it is, we spend a lot of time on these applications.
Right.
And I think that it would be a mistake if we don't consider them a part of now like our primary culture and lifestyles. And we need to really prepare our patients for how to live
with them
effectively with social media.
I agree. And you and I were talking earlier about this, and I think some more studies need to be done about how detrimental social media can be. And I know that they're out there, but I think that it's so impactful and again, can be both good and bad. And there's some good people out there that are sharing really helpful information.
Yeah.
And sometimes I'll see something and be able to learn. Again, I'll say LinkedIn because that tends to be a little more professional based. But one of the detrimental social media things that I see too are some of these mom groups. And I don't know if you're aware about this, but sometimes there will be some shady marketers who will go in and pose on moms who have loved ones that are in treatment groups and try to get patients that way. And for me, that is one of the most despicable things that is out there. And that's, we could list a number of different social media detriments, but to circle back to what you're talking about in regard to how much time we spend on it and the impact that it has on patients. And Do you at Cumberland, do you guys have a class or anything on?
We have kind of it would be more focused on like psychoeducation and community skills.
Sure.
But I think we need to highlight it more.
I agree.
I
agree.
Again, there's a difference between education and change.
For sure.
Right? We all get educated on healthy diets. We all get educated on, making the right decision as a function of prevention or just say no, right?
Right.
In the past, just analogous to or similar to the addiction space. But I think we need more by way of really making sure that people feel safe.
Right.
Because it's it can be really destructive the moment you get out and you're hit with a barrage of notifications or messages about what's happening when you've been in a place, where you're trying to focus on change and you're building healthy community. It can be a mechanism of disconnection, which is just my worry. So
yeah.
Something to pay attention to for sure.
No, definitely. And it needs to be elevated and talked about more. Yeah.
Well,
there's one thing that before we wrap up. So you had talked about Ian taking your nerdy tour.
Yes.
And what was the first thing that I asked to do when I came in for our tour?
To take a picture of our gym, our basketball court.
Right.
Yes, our indoor gym.
And so you guys have the most impressive basketball court that I've seen. And then we went and played a game, and who won?
Yes, I lost in pig to Nikki Soda, which I will proudly say because you're a former basketball athlete.
Yes.
D1?
But no, 2.
Still, D2, right? So I have no shame in that at all. But yeah, it's a great space.
Yes.
And I was excited that you were so excited, and so we got to shoot hoops, and it's really good. Maybe we're gonna have some kind of a basketball competition here in the coming months that you'll have to come back for.
Without a doubt.
Yeah.
So you better come up with a good trophy.
Yeah.
Good first prize.
Well, thank you for coming out to Nashville to visit us. It's a pleasure to host you. It's always good to spend time together. We're going to have fun tonight at the Ryman.
Yes, kid, have never been there before. And I want to give a giant shout out to you too for all the work that you do. And you do so much behind the scenes. So you get very little accolades for the impactful work that you do, but not only impactful work for the field, but like within the individuals that you touch. And so you have a badass story. And so I'm proud to call you a friend.
Thank you. Well, it's, to be honest, it's the teams that we have here, I mean, it's my job to make sure that they have the resources they need to do a really good job. And I just try to stay out of the way, so whether that's the marketing team or the IT team or whoever it might be, there are so many unsung heroes, who are boots on the ground every day doing this call center staff in our organizations that are picking up the phone in an emergency.
That's
Almost
a hard,
every call
job.
is an emergency. So it's just our pleasure, and we're humbled to kind of be a part of the recovery community. So tonight is the annual benefit concert at the Ryman, which we're really excited about. Chris Jansen and company will be playing. So
can't wait.
We're going to go recede to our respective hotels and homes and nap, and then I'll see you there. So
sounds great. Thank you so much for the invitation, and thank you to your team for putting this together.
Yeah, thank you.